Hello, I'm Rachael Babin from the Oncology Network. Welcome to the Oncology Podcast's Experts on Point series. How does ageism affect older adults with cancer? What impact does bias have on treatment options and outcomes? If you recognise ageist attitudes, what can you do to combat it? How does the language we use with older people affect their health? What country is the most ageist? In today's episode, I explore all of these facets with Dr. Michael Krasovitsky. Michael is a medical oncologist specialising in geriatric oncology, as well as upper gastrointestinal tract cancers and breast cancers. Michael is based at the Kinghorn Cancer Centre and the St George Hospital Cancer Care Centre in New South Wales. He is a member of the COSA Geriatric Oncology Executive and lead of the Geriatric Oncology Emerging Experts and Researchers Group. This is a powerful, enlightening and uplifting episode that I hope you'll enjoy listening to. And just a reminder that to access all of our free podcasts, including our brand new series on diagnostics called Beyond the Slide, registered healthcare professionals are invited to join the Oncology Network. Head over to oncologynetwork.com.au to find out more. It's free and it only takes a moment. This is Rachael Babin and this is the Oncology Podcast. Hi Michael, welcome to the Experts on Point podcast series.
Thank you so much, Rachael. It's an absolute delight to be here.
Thank you. Now, I'm always fascinated by the story behind the science. So if you don't mind, I'd like to start with a personal question. What inspired your interest in geriatric oncology?
Always good to start with a personal question, bit of an icebreaker. I always loved oncology, so I started my oncology training in my second year as a doctor, and I think always really gravitated towards the kindness and resilience of the patient. And if you ever need proof of how remarkable a human being can be, you need only look at someone going through cancer treatment. And I always felt this great love and affection, but also just great awe towards patients with cancer. And so I knew that oncology was going to be the field that I went into. And I think during my training in the early part of my consultant career, I found myself more and more engaged in the strength and the vulnerabilities of older people with cancer. I think older people with cancer are often quite easily dismissed. And as someone who I think has an interest in public health, but also in advocacy, I found myself quite drawn to that community. And I would consider myself quite a generalist oncologist. So I actually just really enjoyed treating not just a cancer type, but more a person and a population. And since starting my geriatric oncology work, it's just gone from love to love, basically.
Ah, it's fascinating. Thank you. So you spoke recently at the COSA ASM. How was the meeting?
Oh, COSA was so wonderful this year. It was really nice to see my friends. I know that's probably a really silly and perhaps facile thing to say, but just to have collaboration with my colleagues again, see how beautiful everyone looked after a long couple of years. It was just really lovely. I think COSA resonated a lot with me this year, a real focus on equity and actually perspectives on equity that I'd not been exposed to a lot before. So a real focus on Indigenous health, a real focus on LGBTIQA+ and cancer, a really impressive amount of work in geriatric oncology with a lot of really strong discussions about geriatric oncology, which of course I absolutely loved. It was just a really, not just a scholastically interesting COSA, but actually just a really engaging, collaborative experience and very advocacy focused. And it's always really nice to be in a room with people who are all passionate about the same thing as you. Plus, it was just really sunny and I went for a really nice swim every day.
Oh, I'm so glad to hear it. I think Because it's always been a really special meeting because it brings together so many people from, so many different perspectives. But it's really good that it's back to being face to face and that you got to connect with people again.
Agree entirely. And I think, of all the disciplines in medicine, I really can't think of a more multidisciplinary profession than oncology. It is not doctor-led medicine. Our profession is really fortressed and buttressed by our nursing colleagues. Nurses are the very foundation of cancer treatment, and we form a real community between allied health professionals, nurses, and then the medical specialties of radiation oncology, palliative care, surgery, and medical oncology. And it's just really nice to have all of those different disciplines at the table. So that was an absolute delight for COSA this year.
Excellent. And what did you present on?
So I was busy at COSA. It was wonderful. So my main presentation was called Old, Aged, or Over the Hill, the language of ageism in cancer care. And I spoke a little bit about multiple ways that ageism and ageist language can infiltrate not only the formal but also the informal components of our profession. I spoke about the different types of ageism that exist and the different spaces of ageism that exist in cancer care, and gave a pretty broad definition of what we mean when we talk about ageism. I then looked at some of the data about the prevalence of ageism in different countries, but also the lived experience of ageism, and then focused a bit on how we as individuals can ascertain our own level of ageism in our cancer practice. And then finally spoke about some of the strategies in place that we can all take on to really tackle this insidious but highly prevalent form of discrimination. There was actually one of two ageism lectures that we had at COSA, which is, I have to say, really as an organisation, taking this much further than I think any cancer organisation has done internationally. My very wonderful colleague, Associate Professor Christopher Steer, presented on ageism in lung cancer. And that was an absolutely amazing conversation, specifically looking at that kind of double, if not triple, stigmatization that patients with cancer, specifically lung cancer, can experience being older, having cancer, and having a stigmatized cancer like lung cancer. So excellent presentations on ageism. And I was also lucky enough to chair a session on the best of the best orals in education, which was wonderful. And to be a part of a panel looking at gentlemen over the age of 75 who had an advanced presentation of a head and neck cancer, and the case was a geriatric oncology review of the multiple issues at play.
Excellent. Now, I'd like to come back to the strategies that people can use a little bit later. But before we move on, you mentioned about the data that you presented about how ageism plays out in different countries. I think that's quite interesting. If you could expand on that for me a bit.
Absolutely. So we know that ageism is a universal experience, and it's not necessarily country specific, nor is it culture specific. So we know that there are specific cultures in the world that highly value older individuals. Unfortunately, many Western cultures do not necessarily share that belief. Nonetheless, we do know that in some cultures, older individuals are seen as incredibly significant, fundamental, important parts of society. As the world globalizes, however, I think a lot of that perspective is changing, and we are beginning, I think, as a global community to adopt quite a Western concept of age, which unfortunately is often a very negative perception of age. When we think about ageism as a global phenomenon, there is in fact data from the World Values Survey. And this survey presented 57 countries involved with 83,000 participants. And this survey looked at effectively the prevalence of ageist attitudes and found that globally, 56% of individuals would be considered ageist, with the main risk factors globally, for ageism being younger, being male, and having a lower socioeconomic and educational status. And this World Values Survey was really fascinating because it actually did rank countries from essentially most ageist to the least ageist. And this was high-level data, so we can't necessarily make assumptions about individuals, but from an economics study point of view, we are able to get some idea about which countries are more or less ageist. And the most highly ageist countries are India, Nigeria, Malaysia, Lebanon, and Iraq, with the lowest ageist countries being Australia, the Netherlands, Estonia, Poland, and Armenia. And the United States, interestingly, much more ageist than Australia. The United Kingdom, somewhere between Australia and the United States. So you can see it's not necessarily culture specific because there are many cultural differences between the people of Poland and the people of Australia, and many cultural differences between the people of Iraq and India. Nonetheless, we know that this is a highly prevalent issue no matter what country you're in. And even if Australia is seen as quite a good country when it comes to ageism, we know that in fact 90% of Australians believe that ageism exists, 83% believe it's a problem, and 2/3 say that they've experienced it at least once in the past 5 years.
It's interesting your comments about the UK, actually, because I read just a few days ago a report on the Brighton and Sussex Medical School there, and they found there was routine bias in the treatment of older patients with breast cancer, and then particularly about being advised against surgery. How big a problem is this in cancer care, specifically ageism?
So I think the first thing to say about that question is we simply do not know. So we simply do not know the scale of ageism and its impact on both cancer care healthcare providers and patients with cancer. It's an insidious form of discrimination that really has not been valued in the same way that other forms of overt discrimination have been valued. So we simply do not know the scale of the problem. What we do know is that it occurs at every stage of cancer treatment. And you're absolutely right. Breast cancer has been studied the most of all cancers. In a study that was published just this year in the European Journal of Surgical Oncology by Neil et al., we know that there is an inherent ageist bias amongst practitioners of breast cancer medicine. In this study, they found that 9 out of 10 breast cancer healthcare practitioners showed an at least moderate anti-old association, indicating that they held a correlation between being older and having negative attributes. And we know that when physicians discuss treatment recommendations, healthcare providers are significantly less likely to recommend surgical management of breast cancer patients who are older than 75, even when there is adjustment for their comorbidities, their functional status, their number of medications. So it's not necessarily the complexity of individuals as they age. In many respects, it is simply the number. So the number that precedes the words years old is often enough to dramatically change the way that your cancer is treated. Very interestingly, in breast cancer, there's also data about the way healthcare practitioners discuss cancer with their patients. And again, in this study by Neil et al., a majority of practitioners practicing breast cancer medicine felt that older patients would not want the same level of comprehensive information about their cancer as younger people, and that many healthcare professionals in breast cancer medicine felt that older people would be, quote, more afraid, end quote, to learn that information and less able to, quote, cope, end quote, than younger people. So all of these steps, not only in the way we communicate, the way we treat, the way we diagnose, and formally the way that we teach, all of these are impacted by ageism.
It's really fascinating, isn't it, that there seems to be a tipping point in our psychology that when someone gets to a certain age, they just become an older person. Everything else that they used to be, they may have been a professor, great intellect, but you get to a certain point, oh no, and this information is now too scary to be delivered to you.
It's a really fascinating phenomenon because there is not a universal and obvious correlation between a number and one's health. We know that as people age, they may accumulate health deficits and they may accumulate functional deficits, but none of that is certain. And in actual fact, one of the most insidious and actually one of the most prevalent forms of ageism is the so-called internal ageism or micro-level ageism. And in a really important study by Professor Allen and his colleagues in JAMA, there were a number of questions asked to people between the ages of 50 and 80, and individuals were asked to essentially rate these questions as yes or no. And one of the critical questions that was asked was to respond to the following question, which was, is having healthcare problems part of getting older? And 82% of people between 50 and 80 said yes. So there is this belief that not only we hold, but also our patients hold, that getting older means getting sicker. And I think it's our job as healthcare professionals to not only convince ourselves that that is not true, because it simply is not, but to also empower our patients to realize that that is not true.
Yes, absolutely, because it's a very powerful element of treatment, the patient's mindset. So if we know that people are being treated differently because of ageism, there surely must be a correlation in terms of outcomes.
Yeah, so a huge number of research on outcomes. So I guess the most important thing to say is that if you experience ageism, you will not live as long as someone who does not experience ageism. So in their pivotal report, the World Health Organization very rightly pointed out that mortality is one of the greatest ramifications of ageism. And it's estimated that someone who experiences ageism, and I think critically and most importantly there, self-directed ageism, is likely to live 7.5 years shorter than someone who does not experience ageism. And I think what that reflects is the idea that what we think about our health and what we think about our age probably predicts our health and our life expectancy. So empowering our patients to recognize that health and age are not inextricably linked, that getting older does not, by virtue of a number increasing, mean worse health. By empowering our patients to understand this, we are almost certainly going to be extending their life. We know that ageism is associated with worse self-assessed physical health. It's associated with more comorbidities and worse mental health. We know that people affected by ageism are more likely to have active depression or depressive symptoms and poorer cognitive function. We know that they have worse quality of life and worse functional health. And I think really importantly, particularly when we're talking about a healthcare system, individuals experiencing ageism have poorer health engagement. And that probably is linked in with the higher rates of loneliness. And when we think about cancer specifically, again, unfortunately, this is not a well-studied component of our profession. But what we do know is that it is essentially a universally negative experience. We know that older people experiencing ageism are less likely to get screened for cancer, less likely to be diagnosed with cancer through a biopsy, less likely to get surgery, and less likely to get medicine. We know that for those patients who have cancer, if they are treated for cancer and enter the survivorship phase, those experiencing ageism have a far worse survivorship experience. We know that they're less likely to be given information about their cancer and that decision-making is significantly less likely to be collaborative. And I think pretty critically, and something that we'll be talking about a lot in our forum, is that individuals with cancer who experience ageism are not going to be put into a clinical trial, and that access to treatments, whether it's clinical trials, surgery, systemic therapy, radiotherapy, all of these treatment options are curtailed by ageism. So yes, there are numerous outcomes, and they are not good outcomes. These are the kind of outcomes that we should be up in arms about. And as a community, it's our job to start advocating against this.
Do you think that it comes from training, or is it unconscious bias? The difference in the way that older patients are treated?
I think it's probably a combination of multiple things. I think that growing up, we are taught that old is bad. We see depictions of older people in the media as being frail and weak and disengaged and sad, and one of my most hated terms, dottery. And we grow up recognizing, I think falsely, that young is good and old is bad. And by the time we enter medical training or nursing training or physiotherapy training, we are imbued with this social belief that as you age, you decline, you become less important, you become less engaged, and that the most important people are the youngest people. And we see this every day in the news. We see this constantly. During COVID, we didn't care as much about older people dying as we did about younger people dying. We were up in arms when people in their 30s died, and yet we did not have the same degree of sadness or angst or discomfort when we heard about older people dying. So we grow up in this culture, and then we enter medical school or nursing school or allied health training, and it's never dismantled. It's almost certainly just perpetuated year after year after year. And then we enter a medical system which again talks about bed block and frailty and older people taking up beds and taking up space and complex discharges. And we just the concept gets reinforced over and over and over again that it's not fair that older people are taking up beds that younger people could be using, older people taking up ventilators that younger people could be using. And it happens throughout our training and throughout our careers. And it's only when we stop and we say, why am I not upset about this? Why am I not as sad about this older person dying as I am about my younger person dying? Why am I more likely to breathe a sigh of relief that the 80-year-old doesn't want chemotherapy compared to the 40-year-old? I think we really need to accept that these things exist, and actually let's not judge each other for them. Let's not be critical to our colleagues. Let's recognize that our training programs don't dismantle this. We live in a society that perpetuates it. The establishment of our oncology framework similarly doesn't dismantle or fight against ageism. Let's not be too hard on ourselves and say the entire world has to change. Let's simply recognize that as a community we have this weakness and that it's our obligation and also our privilege to work against it.
It's fascinating. It's a very refreshing, positive approach. I think sometimes it can feel a little bit depressing when we realize quite how bad these problems are. And it feels like it's never ending. There's so much inequity. So it's really refreshing to hear that. Now, in your experience, are there any differences in specific patient cohorts? So do you notice more ageism, for example, according to sex or ethnicity, even tumor type? Are some subspecialties more ageist than others?
The answer to that is yes. And I think the key message here is that inequity begets inequity, and inequities can worsen pre-existing inequities. So an English-speaking, normal weight, Caucasian Catholic man who is 75 will be treated differently to a non-Caucasian woman of the exact same age who speaks English as a second language. And that's because inequity begets inequity. And if communication is difficult due to being culturally or linguistically diverse, if your lived experience is different from a sexual identity point of view or a gender point of view, that will beget a certain inequity. And these multiply and coalesce, as it were, to the extent that our inequities essentially stand upon one another and we become stigmatized on multiple levels. We know that the very nature of being older and having cancer represents a double stigmatization. You're stigmatized for being older and you're stigmatized for having cancer. And if you add on to that being lower socioeconomic status, having a lower educational status, being female, being an Aboriginal or Torres Strait Islander, you add these layers to your personhood, all of which come up against a system that does not embrace, accept, or celebrate you. So yes, the more minority labels our society piles upon you, the more likely you are to experience ageism as you age. In terms of specific tumour type, unfortunately, probably as a result of the numerous ways that inequities coalesce, we do know that breast cancer is a field where ageism is highly prevalent. We know that our breast cancer colleagues do a lot of research, and it's probably related to the data that we have. But we do know that ageism is prevalent in breast cancer medicine and breast cancer surgery. Similarly, we know that older people are significantly less likely to be treated for advanced upper gastrointestinal cancers than younger people. The tumour-specific nuances of ageism are otherwise quite opaque because we simply do not have the data yet. I would say, in general, tumours that occur more commonly in already disadvantaged groups are more likely to experience ageism. So, for example, hepatocellular carcinoma related to individuals with hepatitis B or C from non-English speaking backgrounds, I would say that that's a group at high risk given the existing inequities. But the specifics of which tumours are worst, I cannot tell you, and I look forward to being able to do that in the future.
Excellent. Yes, it feels like this is the beginning of a conversation and there's a lot more work to be done. Now, just before we wrap up, just to bring you back to the practicalities, I'd like to discuss strategies. So what advice would you give to your fellow clinicians and team members about how to tackle their own unconscious bias towards older people? If you're listening to this and you think, gosh, do I do that? Okay, yes, I do that. So how can I stop it? What can I do to change?
Well, I hope that's what people are thinking. And if you are, I applaud you, because this is not an easy thing to think. It's not easy to consider your own actions and critically appraise them. The first thing that I would say is it's real. This is a real phenomenon, has numerous negative impacts on our patients, not to mention the impacts it has on our older colleagues. So the first thing I would say is it's real. And if you feel that some of your practice is ageist, recognize it, but don't berate yourself. We have grown up in a culture that perpetuates ageism, and we have trained in a culture that has not dismantled it. We are now all working in institutions that continue to use ageist language. So this is not going to change overnight. And I don't want people listening to this podcast to leave and think, I'm terrible. I've been doing this. What this podcast and what our educational program is all about is simply beginning the conversation. So if you think that you might be experiencing yourself ageism, or if you feel that you might be approaching different patients or colleagues with ageism, just name it. Name it in your own mind. Name it out loud if that's something that you feel will be of benefit. And then think about it. And just think about what the specific nuances of your behavior are. Is it that you are thinking ageist thoughts? Is it that you're feeling ageist feelings? Or is it that you're acting in an ageist way? And some of those examples with thoughts are, as we said before, this person is not up to learning about their cancer. That might be the thought. And maybe you can challenge that and say, well, based on this person's age, I actually cannot make a judgment about whether they're up or down to understand or want to know about their cancer. So rather than going in with this idea or this thought that you're going to be able to anticipate what an older person thinks, go in with an open mind. Similarly, if you're thinking about your own actions and you feel that your ageist vulnerability, for lack of a better word, is feeling that you feel a certain way towards older people, name it. So if you're in clinic and an older person to you is talking and you feel frustrated because they seem to be talking off track or telling you about their life and you're running behind in a busy clinic, recognize that feeling. I am feeling frustrated. And recognize that that in and of itself has ageist connotations. I'm feeling frustrated at this old person for talking about something I'm not interested in. Name it, and then think about how you can approach it. And think about recognizing that it is not an inherent truth, what you're feeling, and that it's something that you can engage with and begin to change. And I think lastly, on the final point of ageism, which is action, think about your actions. An 82-year-old person sitting in your clinic who tells you that they don't want to take chemotherapy for their cancer because they've heard it's really bad, rather than breathing a sigh of relief, which is what you might well have done, think about what your decisions are related to ageism. Could it be that you're willing to accept this person's actions because it comforts your own sense of what an older person is or is not, quote, up to? Or do you feel like questioning some of that internal ageism that the person opposite you might be experiencing? Do you want to take it an extra step and ask them why they're worried that being 82 would preclude them from chemotherapy? Seek their own expertise and maybe even begin to question some of the ageism that they might have inherited. So that's a slightly long-winded answer, but what I would say to those people who want to tackle ageism is think about your thoughts, your feelings, and your actions towards older people with cancer. Recognize that ageism may be contributing to those thoughts, feelings, and actions. Don't be cruel or critical, but do make an intentional decision to think about the way that you think, feel, and act. Call out behavior that you're not proud of and do what you can to change it.
Fantastic. Thank you. As I said, it's so nice to finish a discussion like this on a positive note with some real practical things for people to think about. So thank you. Are there any resources, organizations, events, groups that you might like to mention that?
I'm really proud of COSA, the Clinical Oncology Society of Australia. COSA have really taken ageism on as an organisation, and I think Australia is really leading the way when it comes to tackling ageism. That's something that we should be really proud of. When it comes to specific ways that people can learn more about ageism, the first thing I think to say is that we are hosting an Ageism in Cancer Care Forum on the 22nd and the 29th of November. It's going to be a really wonderful look at how ageism impacts on older people with cancer and older healthcare workers, and all the information can be found on the COSA website. Other organisations that I think are really important in this space are, of course, the United Nations, who have declared this the Decade of Aging. And the United Nations Global Report on Ageism is probably considered the Bible by many of us working in this space. I think the Benevolent Society in Australia has also had a very significant role in bringing ageism to everyone's attention. And the Every Age Counts program through the Benevolent Society has been critical in bringing this issue into public discourse. And finally, if you want to know more about ageism, particularly if you're a healthcare provider, you can always ask your patients. because actually most patients will have had an experience of ageism. Based on data from the US, it's estimated that 94% of individuals regularly experience one or more forms of everyday ageism, and that's for people 50 to 80. So if you want to learn about ageism, ask an older person. They will have felt it, thought it, and acted in a way that is related to the pervasive ageism in our society. So don't be afraid to ask people for their own expertise. And of course, you can always ask me. I'd always be happy to chat.
Thank you, Michael. It's been a really fascinating insight. And yeah, please just keep us posted. We will include links to all of the organisations that you mentioned. And good luck for the forums. I hope they go well. And thanks for coming on the show.
My absolute pleasure. And I'm always around if anyone ever wants to chat with me.
Lovely. Thank you.
Thank you, Rachel.
You've been listening to the Oncology Podcast's Experts on Point series, brought to you by the Oncology Network. To hear more podcast episodes, head over to our oncology portal at www.oncologynetwork.com.au. Registration is free for healthcare professionals and will give you access to exclusive content, such as our fantastic diagnostic series, Beyond the Slide. If you've enjoyed today's episode, please share it with your colleagues. This is Rachael Babin, and this is the Oncology Podcast.